Well, good day, everyone. This is EMDR Chat with Curt and Michelle. I'm Dr. Curtis Roundson.
And I am Dr. Michelle Gottlieb. And Curt, we have a
What?
guest.
Well, what's on our
I
plate
know.
today? It drives me crazy.
Okay.
It
Curt,
drives me crazy
you know,
when you do this. It drives me crazy. When
you enjoy
do
it. Just admit it.
this. So, what's the topic about today? I'm crazy to know.
So so funny that you use that word, Curtis.
Oh.
So one of the things that we often hear people ask about is, can you use EMDR therapy with our clients who are psychotic, who are suffering from psychosis? And the short answer is yes, but we're going to go for a much longer answer now. We have our guest, Dr. Mary Eason, who specializes in working with clients and EMDR therapy and psychosis. So, Mary, we're so glad you're here.
I'm
Welcome.
So glad to be here. Thank you so much for having me.
So, Mary, first, would you just tell us just a little bit about you and how you got into working with this population?
So I'm a psychologist and I have a private practice in Fullerton. And in a previous life, I was a financial analyst and I was super unhappy and I went to therapy. And I said, in my process of therapy, I said, oh my gosh, I should have been doing this the whole time. And so my first job was as a psychiatric aide at Brea Neuropsychiatric Hospital here in Southern California. And I was fascinated. I was hooked. I worked in the locked unit for about 3 years before I moved. That hospital closed and I moved a couple different places and have worked in inpatient and locked units and subacute partial hospitalization, intensive outpatient, and actually had a private practice, a first iteration of my private practice that was just with seriously mentally ill clients. And so I really do enjoy helping people work through this process because it's terrifying. And kind of seeing people come out the other side and feel like more command of their life and feel safer and have their functioning improve really was really meaningful to me, even though I have done different things since then. I think I've always held on to that.
So many therapists are scared of working with any patient who has psychotic symptoms. And what do you think are some of the greatest misconceptions that we have about doing that? Working with, particularly with EMDR and psychosis?
Well, I think it just initially, it's really frightening to us internally, just as human beings, to feel as if you lose your grounding and your experience of the world. And then I do think it can feel really overwhelming to be in the presence of somebody who might feel so kind of out of touch with what's going on around them. And what I find is that I think what I feel like kind of touched me is that curiosity. And so I would spend hours just talking to people about what their experience was. And I think you can see the themes of kind of connect with EMDR, the feelings of safety and the feelings of being out of control. And if you listen like with curiosity and allow them to talk about what their experience is, I think you learn so much. But I think we have to get over, that just internal response that this is, I can't help them, I think, which is that fear of that. We used to wake up, everybody who worked on the lock unit at Brea, we had these kind of wine-colored scrubs that we would give the clients who would come in emergency or maybe off the street. They would be brought in by the county. And all of us had dreams of waking up in the unit in those wine-colored scrubs. And I think that really speaks to just our internal anxiety about this experience. And so I think that's what blocks, if I'm, kind of being quite honest about my own experience in the process.
Sure. We have a therapy now that helps with that kind of thing.
I know. I think it's great. I have worked through that, but it was kind of fascinating. That was like it was a universal dream state that everybody who worked, especially in the locked unit, would have. Because I think the wine-colored scrubs were really unique and stood out for us.
Yep. Oh yeah.
So, what would you say? I mean, again, coming from an AIP perspective, and the way we understand most everything with our clients come in is through that trauma-informed lens. How do you see psychosis through a trauma-informed lens?
Well, I have lots to say about that. I'm kind of debating about, should I go back in history and talk about how everybody used to see it and now we have forgotten, what Pierre Genet saw or what Carl Jung saw.
Maybe that's a good place to start.
So I think historically there was contemporaries, Carl Jung, Bueller, Emile Kraepelin. I don't want to leave anybody out. Pierre Genet, especially don't want to leave out Pierre Genet, Freud. And they were all seeing the same clients, and they were all seeing the significant impact of trauma on these patients that they were seeing. And they were seeing them from different lenses. And nowadays we would think about that like medical model lens versus the trauma model lens. And I go into a lot of detail of this in my training, and there's some great YouTubes if you're interested. Andrew Moskowitz has a great YouTube series on this if you're really into history and you want to know the details about this. But basically what happened is we have split our perceptions of really seriously ill clients and their presentations into these two camps. It's all biological, or it's all trauma. Although I think us trauma people don't always think it's all trauma. I think we think it's like a combination. But I think that rift, really the Freud giving up his idea and his what he learned from his patients was that incest was really traumatic, and incest caused a lot of dissociation. And then because he got such really harsh feedback about that from his local community, he backed off of that. And when he did that, he created such a rift in this community about looking at dissociation and the impact on psychosis and the impact from trauma, that really pushed Pierre Genet's work into the shadows, so to speak. And so we have been moving in this space for 100 plus years, thinking about it more from Freudian ways or also from the medical model. And so I feel like I kind of got lost in this history and talking about it contemporarily is I think EMDR therapists see the impact of historical trauma, neglect, attachment wounds in their clients with psychosis. And if you're listening with that curiosity, you can see it too, that psychosis presents, it's just an extreme state of overwhelm. For what some of our clients who have had similar experiences don't have psychosis, but for some clients that is intolerable for them. So when you're thinking about treating psychosis from the AIP model, you're going to want to look for those themes, and you're going to want to look for the metaphors that exist in the psychotic experience that could be tracked back to trauma.
I like the fact you brought that. One of my favorites is Pierre Genet, because he was one of the very first. He coined the phrase dissociation, and
yes,
I remember several years ago, Colin Ross was doing a workshop, and he had a definition of dissociative identity disorder up on a slide. He went through it, and everyone was sitting there. Oh yeah, that's a DID. That's a DID. And then he puts the author of it, and it was Emile Kraepelin's definition of schizophrenia.
Yes,
and
yes.
How that all, like you said, the rift. It was so profound. Yeah.
Right. And then we had Kurt Schneider come in with his Schneiderian symptoms, and when he wrote that book that got translated to English like in the 50s. And of those 10 Schneiderian symptoms, I think 7 of them are really more reflective of dissociation.
Dissociative, absolutely.
Yeah, and so I think that it becomes very, very confusing when we're trying to diagnose and see. And so I think I kind of sit in this space where I see psychosis, or I'm looking for the psychosis more as a dissociative process than a actual biological process. And I think we can see that in our clients when they're on multiple medications that are designed from the medical model to treat their symptoms, yet they don't treat the symptoms. And so I think that would be your first clue they don't work. And so as a clinician, if you have a client, multiple hospitalizations, multiple meds, yet they're still having experiences that aren't really connected to reality, I think you need to start looking at that's dissociation, that's the root, that's the trauma.
So this is a conversation that Curt and I have been having a lot lately of that dissociation continuum, and what actually fits on there and what doesn't fit on there. And so, Mary, I'm now curious, when you look at that continuum that goes from that, normal dissociation all the way through to people who have DID, do you see psychosis as fitting on that, or do you really see that as something separate off, not on that dissociative continuum?
Such a good question. So complex. If people want to learn more about that, Colin Ross is where to go. He sees he would like to redo the whole continuum of schizophrenias and talk about them in that dissociative schizophrenic kind of theory that he has, which I think is really valuable. But like in my work and in my EMDR work with psychosis, one of the first things I do is I give them the DES or the mid. I generally default to the mid because there are clients out there that are psychotic who don't have any dissociation at all. And you can just do your 8 phase just like normal and they don't decompensate. And we can notice a real impact in desensitization of their trauma experience. And all the initial research, the first study on EMDR with psychosis was just in 2010. And it was out of South Korea, and they just did regular 8 phase. They didn't do any dissociative screenings on their clients. I think they did the PANS, which is the positive and negative symptom scale. And they gave a couple like a depression or anxiety inventory. And then they just did the 8 phase, and they had excellent outcomes with no decompensation. And so that is really possible for anybody listening to this who's trained in EMDR, who feels a little fearless. If their client doesn't have any dissociation, you can just do the 8 phase. Where it gets complicated, when you're thinking about that continuum, Michelle, where the level of dissociation and the impact of trauma and the amount of trauma, and I think too on the far end is like the neglect, the absence of presence in somebody's life. You're looking at more dissociation, more, oh my goodness, my brain just kind of froze up. Attachment, like attachment wounding. The more severe it is and the more long lasting it is, you're going to be at that farther extreme. And so then you kind of have to treat them more like you might treat your client with dissociation, more phase 2 work, more preparation work, more present trigger work versus going in the like really into the deep early trauma. You'll throw them out of their window and they might become more psychotic. So maybe I jumped ahead in the questions a little, but that's kind of how I see it.
Well,
you're good.
You're really tapping on to the fact of some of the adaptations of the protocol that we have to make sometimes with psychotic individuals. And more current events, and even the psychotic symptoms themselves can be a target in EMDR therapy.
Absolutely,
So,
especially the kind of really intrusive images. A lot of people who have psychosis have those really intrusive images, which probably have a theme of "I'm not safe," because they're terrifying, and you can absolutely target those themselves with EMDR therapy, and that's really effective. And imagine what happens if they no longer feel panic about that. I want to encourage people to really use EMDR therapy with psychosis, because if we can desensitize that, their ability to live their lives and manage all the other stressors they have improves. So that's
and a number of times that I've seen visual and auditory hallucinations actually go back. It may be a metaphor, but often go back to a traumatic incident that has been projected out there into these quote hallucinations.
Absolutely, just like phobias do, right? I feel like it's kind of similar. That manifest in a different way.
So I know right now we have listeners who are saying, wait, hold on. Are you saying EMDR therapy can cure psychosis?
I am saying that EMDR therapy will work with people who have psychotic symptoms in the same way it works with people who don't. That you have an event that happens, and if you have an extreme response to that, like you hear voices, and we can desensitize that, yes, that they might have a thought about that voice, but it's not going to get stuck. It's just going to move through. And is that a cure? I don't know. Is it the same way we, my air quotes of curing our clients, who just have significant trauma? No, they still struggle with things, but they just aren't as impactful in their life. They can learn to manage them and they don't kind of take over.
Right. Yeah. I think about like some of our clients who have schizophrenia, who they still have schizophrenia at the end of treatment, but their resilience is more than the intrusiveness of all of the symptoms just aren't there, and they get to live their life better.
They do get to live their life better. And I think we're doing a disservice. If you think that some of the research says 50% of the people who present with psychosis have trauma. And 1 in 8 people who've been diagnosed with schizophrenia meet the criteria for PTSD. So we're actually doing them a real disservice if we're just doing skills training and med management, and we're really ignoring just what is underneath all of this experience that's fueling that. And, there's so many diagnoses and presentations and medication that cause psychosis. There's also viral COVID and Epstein-Barr can cause psychosis. I feel like we have to really get in that history taking and really find out what is under the current experience. And that takes curiosity and patience and fearlessness, I think.
Absolutely.
Those such good words: curiosity, fearlessness, all those things that we tend to, I think for a lot of people who, the fear of working with psychosis is that they're going to have this huge psychotic break and I'm going to have this person running, screaming through my office or whatever, right? I won't know what's going on. And you might not.
We call those coworkers.
Oh yeah, that too.
Can I just say that rarely happens.
Right?
So I think, it depends upon where, how comfortable you feel and how confident you feel. And the odds are if you're in the hospital, you have a really great milieu. Ad de Jong has his 3 methods, and I talk a little bit about this in my training. And he's doing great work with people with psychosis. And, I think it's just like we think about people with trauma that we're treating, they get better. Because we're desensitizing the traumas. The people with psychosis get better. So you're in your office. I think the rates of having somebody who has psychosis go out of their window of tolerance are about the same for your regular clients. That's just in my personal experience. I very seldom have them go out of their window if I'm picking the right target and creating an environment that feels safe and I'm not pushing, like doing lots of passes in my sets. I have things really kind of contained the same way you would do with somebody who has dissociation, maybe severe agoraphobia, severe anxieties. It's the same.
Mm-hmm.
And again, I think people listening just panicked when you said, if I choose the right target. Oh my God, what if I choose the wrong target?
I know, right? So we want to collaborate with our clients. And, in our conversation, in our history, in our phase 2, you can tell what topic is going to throw them out their window. And so you pick something smaller. I often think of it as like just shaving off the top of what's going on with them presently. So if we can reduce and desensitize the impact of that, it gives them more space mentally to deal with things that are more complex or more long-standing. And so I kind of, I think we talked earlier, Curt, about just that work, that present trigger work.
Yeah.
And picking small targets in the beginning. And I think, although I want to caveat this and say that in a lot of the research on psychosis, they're not doing this. They're not testing for dissociation. They're going and creating a pass prong from the present triggers, and they're doing the work, and they're having great results. And so
wow.
I don't want to say you have to do present trigger work with everybody.
Right.
It's going to depend upon probably the level of dissociation that your client is coming to you with.
Michelle's favorite line, it depends.
It depends. Yeah.
Yeah.
Yes, it does. Yes, it does. And I remind people all the time, EMDR therapy is a very client-centered therapy, right? We don't have a one-size-fits-all.
Mm-hmm.
Mary, do you have anything, though, that you want to caution people about with this population?
So I think it would be important, like with anybody, that we're always kind of paying attention to. So what is the diagnosis is kind of where I would start. So if I have a client who has bipolar and in their manic episodes, they have psychotic experiences, one of the things I'm going to make sure is that I have med management first, right? So it depends upon what I'm working with my client. It's going to depend upon what my assessments look like. So I'm going to do the mid, and I'm going to probably do the DES first as a screener, and then I do the mid if I'm concerned, like the DES might be high. I'm going to do the mid. I'm going to get more detail. I'm going to talk to my client about the mid. I'm going to prep my client. I am not going to just jump in and do our 1 week history taking, the next week safe, calm state, and prep, and then the third week start my treatment plan. These clients are going to take longer in the history taking phase, and so that would be my caution is in your history phase, you really want to get a firm idea of how long the voices have been happening, how long the psychotic experience has been happening, when the first one was, what their mental health history looks like. And so my caution would be not to speed through, but to take your time. and gather as much information and listen to your client about what their experience has been like. Did that
So
answer your
important.
question?
Absolutely.
Okay,
and again,
all right.
back to client-centered again.
Yes. Yeah.
So what I want to tell everyone, if you want more information, Dr. Eason is doing advanced training on working with EMDR therapy in folks who have psychosis in February of 2026, and then it will become an on-demand course. There is a book out by,
Paul
tell me his
Miller.
name again. Paul Miller, thank you. EMDR therapy.
Yeah, you want
and
me to say
schizophrenia. Yeah, go ahead.
EMDR therapy with schizophrenia and other psychosis. Great book. Really wonderful book about conceptualization, because we didn't get a chance to talk about that today, but case conceptualization is really important. So maybe another time.
And of course, just consultation too, if that's just not a population you've worked with.
Absolutely.
Get your education and get consultation.
Yes.
Thank you so much, Mary,
Thank
for
you.
spending time with us.
I've really enjoyed it. There's not enough time to go into all the
Right.
detail about this topic. So I hope to see everybody at the training.
Yeah, we'll have to have you back. Thank you, Mary.
Thank you.